Hi, my name's Hamilton Ayres. I'm a general practitioner in Melbourne. I'm fortunate enough to work full-time in skin cancer medicine. So I'd like to talk to you just quickly about a case that walked in my door the other day, which is a good example of a few of the different ideas we are talking about in the course. It's a 59-year-old chap. He's previously had a lot of non-melanoma skin cancer. And of course it's his first check in about 3 years, not for want of trying to get him back with a series of recalls. He's turned up with this spot on his neck. And of course it has to be removed right now because he's going on holiday. It's the holiday sign. So what do you think this is? It's grown pretty fast. Looks like a raised mushroom growing out of the side of his neck. You're probably going to put your money on either keratoacanthoma or squamous cell carcinoma, aren't you? But what are we going to do about it? Well, I suppose you're within your rights to refer. That's not unreasonable if you don't feel surgically capable of biopsying that lesion. But really, I think rather than just biopsy it with a sample, I think excision is the way to go. Because whatever it is, it's got to be tested, and keratoacanthomas, even if it is that benign entity, the lab needs as much of it as possible to make that distinction between Ka and SCC. So excision biopsy is the way to go. But what's nearby? Because this is roughly what it's going to look like. Even if you do a short, stubby 2.5 to 1 ellipse, like I've drawn, you're near some structures there, aren't you? So this is tiger country. This diagram just lets you know about all the nerves that are floating around that area. And you can see that at the intersection between a line inferior to the earlobe and the posterior border of sternocleidomastoid is Erb's point. And what you find there is the spinal accessory nerve coming out. You don't want to prang that. But if you are aware of what's in the vicinity, you're also near the greater auricular nerve, so you're going to make the patient's earlobe go numb. There's lots of things that are going to happen if you're in the area. So it's good practice, if you're working in this area, to anaesthetize it and ask your patient, do you notice any change in your earlobe? Have you noticed a decrease in your ability to shrug your shoulders? Because that means you are close to the nerve. It's just worth documenting. Even if you refer the patient on, you can say, and by the way, when we did the biopsy, the patient had these symptoms. So, how would you cut this out? Well, I chose to excise the lesion as a circle down to fascia and then send the dog ears separately, more superficially, just to have a more cosmetically acceptable result. And this histopathology result lets us know that, we got deep margin clear by 1.2 mils and about 4 mil clearance on the lateral margins. It's completely excised, and it was in fact a well-differentiated squamous cell carcinoma. So this patient was somewhat lucky. And I was very careful, probably took twice as long to do as something I would normally do anywhere else on the body. I made sure I used loupes because you need to be able to keep your eye out with magnification if you're going to work in these dangerous areas. You need to be able to see what's there in case you see a nerve. You can't put your knife through it. This patient was reasonably lucky. He showed no evidence of lymphadenopathy either. Don't forget to check that, because let's say it came back as incomplete and you want to refer the patient off to plastics or head and neck surgeon, and you haven't actually palpated the lymph nodes in the cervical chain. How do you know if the patient needs to be seen tomorrow or maybe get radiotherapy opinion? Just a few things to think about. It's never as easy as it looks We're just trying to keep you aware of all the little subtleties involved in cutting out a skin cancer on a neck. I hope you found it interesting.